All right, so I think we're live on YouTube,
Hello, everybody on YouTube.
and let's go ahead and go live on. Okay, so I'm gonna let's go
Okay.
live on. I think we're on Instagram too.
I don't see it on my Instagram. Oh, there we are. Okay. I'll be coming
Hello,
up in just a
everyone.
second. Okay, I sent you a
Hello.
request.
All right. Looks like we got Dr. Q on. Hello, hello. Happy Friday.
Hello,
Welcome in.
everybody.
Hi, Miss Mayor. Hi, Chris.
Hello.
Hi, Wireback Candles. Nice to see you all. Thank you so much for joining us today. It's been a little bit, but we're back and we're ready to answer your sickle cell questions. But before we do, drop down where you are tuning in from. Would love to see where you're joining us from. Let's see. Good evening here. Oh, where are you? Zara Ice. Lancaster, Pennsylvania. Nice, East Coast. Boston, Virginia. Atlanta. Okay, y'all are on the East Coast then.
Where it's cold and snowy.
Halifax, Canada.
Oh,
Kenya. Oh, oh. Baltimore. Wonderful. Well, I hope you guys are all staying warm, or I hope it's warm where you guys are. New Orleans, love it. India, love it.
oh, wow.
And oh, it looks like we already have our first question. You guys already know what to do. Um, Nigeria. And okay, so this first question, Dr. Q is has a lot to say. I'm just gonna say that.
I'll keep it low.
Well, it's about even flow.
I know, I saw that.
Okay, you saw it. Okay, so here we go. I'm gonna go ahead and put your question here.
Okay, so I years ago, Evenflow's been around for quite a while. So years ago, I got in touch with them because they say it's like there's been a study or something, and I got in touch with them trying to get more information about Evenflow. Is that what it?
Yeah, even
Yeah,
flow.
even flow. And they never got back to me. They didn't, when when they get an email from a doctor, they probably think, oh, let's not go there. But these um, things like even flow and some other what people call natural uh, medications or whatever, they're not vetted by anybody. So even when you take vitamins, which I do, if you look on the bottle, it should say USP. That means that
If you're in the US, right?
no, it means that
Oh, period.
that it's been vetted by the pharmaceutical regulators, and what's in the bottle is what's on the label is actually what's in the bottle. But things like even flow and some other things, you don't there's nobody vetting that, so you don't really know what it's in there and what it does. And you know, I just feel like you're spending a lot of money on something that may not work. Even flow's been around for a long time, so obviously somebody's buying it or they wouldn't be selling it anymore. But um, I think when you are putting things into your body, you should have some reassurance that what as to what's in the substance you're putting in your body and whether or not it actually works for you. Because if it doesn't, then you're wasting your money at the least, and then you could be, hurting yourself if you're taking even flow instead of my favorite drug, hydroxyurea, or something like that.
So the take home is this stuff isn't regulated, and
Yeah, it's
so
not regulated.
yeah.
It doesn't actually mean it's not, it doesn't mean that that it could never possibly be helpful. It's just that because it's not regulated, you're not really sure what's in it. So that's the problem. It's not that it may or may not work to me, because if it doesn't do anything, the worst thing is you're just spending a lot of money for nothing. But if you don't know what's in it, it could really be hurting you and you just don't realize it. So that to me is the worst part. The money, you know, it's anything that you do, like if you didn't have insurance and had to buy hydroxyurea, it would be over a year, you would be spending a lot of money on it. Fortunately, most people with sickle cell have some kind of insurance to pay for that.
So I see, because it's not regulated, they can really put whatever ingredient they want in it. And then also the other side to this, to my knowledge, and you know, um, we can double check to see there aren't any studies or peer-reviewed studies surrounding even flow's effects for sickle cell. And
Right.
so that's the other side of the coin is because there aren't studies, you kind of need proof to know if something works or not. And so if there aren't any studies, then it's a risk, it's a gamble if you do take that. This person says my daughter's doctor says her and other patients really like it and it works. Um, Yes, that's what I was told. So yeah, I mean it really is at your own discretion, at your own risk, but also just go in informed, go in knowing that there aren't any studies on it, go in knowing that nobody's really checking to see what the ingredients are in this. And if you still feel you want to try it, then just have that information at your disposal. All right. The next question I have here. Is it possible for your genotype to change over time from a drug or from herbs?
No. So your genotype, that is what your genes, that's your DNA. That's kind of who you are, right? So even if you get, say, a bone marrow transplant, your genotype isn't changed. Gene therapy doesn't change your genotype. So if you were to have children, you would still have the same risk of passing the sickle cell gene on to your children. So it doesn't change your genotype. The medications and the treatments change, say for bone marrow transplant, you have your bone marrow is changed to make normal red blood cells. The rest of your body is the same as it was before the bone marrow transplant, with the exception that you may be sterile from the chemotherapy that you get prior to getting your transplant. The same thing goes with gene therapy. It only affects your hemopoietic system. It does not affect the rest of you, except again, there's a possibility uh, of being sterile secondary to the conditioning or the medication they give you before you get your transplant or your gene therapy. And but you're still, everything else is the same. All the treatments affect your bone marrow. Um, I mean, that's what they're supposed to do, but then there's side effects such as sterility. And there's also, with a bone marrow transplant and stuff, you can have, side effects from that, graft versus host disease. You can have liver problems that are resolvable, treatable, but there are other things that happen to you when you get conditioning of any kind.
So no, your genotype wouldn't ever change. What you get is what you get. Also just to kind of build off of that, sometimes we get questions like, will sickle cell trait ever turn into sickle cell disease? No, it will never turn into sickle cell disease. You will always have sickle cell trait unless, you know,
Right.
given what Dr. Q's talked about. And I have SS, so I will always have, SS. And drugs and herbs don't change your genotype.
Yeah, even the really heavy duty therapies, gene therapy, bone marrow, they don't change your gene.
All right. Thank you for the question. These are great
That's
questions.
a good question. That's a very good question.
What is your thought on taking birth control and being a sickle cell patient?
Uh, I think it's okay. You have to, there, progestins actually seem to decrease the symptoms of sickle cell disease. Estrogen can increase your propensity to having blood clots, thrombosis. So what you need to do is, if you're going to be on birth control, those things are, they're not forever, that don't happen to everybody, but make sure you talk to your hematologist, your sickle cell doctor, that who knows your history, to make sure that there's nothing that would be different from in you compared to everybody else. Um, and also to advise you there's a lot of different kinds of um, contraceptives, to advise you, the ones that would be the best for you to take. And I'm not going to go into that because we don't give advice on what to take.
But it is important to have your GYN work with your hematologist.
Right.
Sometimes what's happened with me is, and this does happen, right? My hematologist be like, "Oh, you should ask your GYN." And then you go to your GYN and they're like, "Oh, you should ask your hematologist." So you kind of really have to kind of get them together or, work together on what looks best for you because both of them will kind of defer to one another, right? And sickle cell is a multi uh, uh, organ and complex disorders. So it really is both at the end of the day. But they kind of have to come together to um, determine what's best for you.
And at GYN, sickle cell is a rare disease. So you could go to your GYN unless you're in a high risk GYN program, and they may not have ever given a contraceptive to someone with sickle cell disease, and they may not really know very much about sickle cell disease. So the person that you really have to get your hematologist or your sickle cell doctor to talk with the GYN person as to what would be the best contraceptive for you.
And it is, I'm told it's very important to have a GYN, and I'm missed a couple of appointments, so I need to get back on that. But um, I've been told by my sickle cell specialist that I definitely need a GYN and I definitely need to upkeep appointments with that. So if you're anything like me, don't let those appointments go by, and make sure you're scheduling at least an annual with your GYN.
Yeah, because every woman should get a pap smear,
Yeah.
all the stuff that people who don't have sickle cell disease go to a GYN for, you should be getting.
All right. Question, is it normal for your lungs to become damaged from sickle cell from acute chest syndrome?
Unfortunately, yes. So, as people, depending on your, what therapy you're on, like whatever, and your history of asthma, allergies, and acute chest syndrome, over time you can develop lung disease from sickle cell. And I'm talking about, someone who's 40 or older can actually have chronic lung disease precipitated by their sickle cell disease. So that's why it's good sometimes for your to go and see when in the clinic where I did pediatrics, but we still had kids go to see pulmonologists, cardiologists, and whatever, just because we wanted to make sure that they didn't have pulmonary hypertension and that that other problems or they if they had asthma, their pulmonary function was okay and all that kind of stuff. So you know sickle cell disease is a multi-organ problem, so that you do need to see different specialists to make sure everything's okay, especially as you get older, after when you're in your 20s and 30s. One of the big problems with sickle cell is that sickle cell disease, all the sickle cell centers were actually pediatric sickle cell centers to start off with years and years ago. Um, so the care for pediatric patients with sickle cell disease or kids tends to be a little bit better than for adults. And there's a transition period where after 18 or something, maybe your insurance or in California, Medi-Cal won't pay for you to go see a pediatrician or be in that program. And that transition period is really fraught with difficulties. You need to really prepare for that when you get to be like even when you're 12 or something, and be ready to transition to an adult program. Between the ages of 19 and about 25 or 22, the hospitalizations and even the morbidity, mortality of people with sickle cell disease goes up because there's this window where they haven't prepared and they're going to see the ED. That's kind of like their doctor because they don't really have a doctor. So if you're a parent with a child who has sickle cell disease who's 12 or 13, or you're 12 or 13, you should be thinking about who's going to take care of me when I'm 20, and make that transition and find a good doctor to take care of you, because that transition period is really fraught with difficulties if you haven't prepared for it.
Dr. Q, do you have a pen?
Oh, am I clicking my pen?
Yeah, I don't know if it's just me.
I need what are they little spin things?
Oh, one of those gadget toys or the
My
typical
wife always
Gemini.
tells me that. Stop clicking your pen.
Oh my gosh, you're such a Gemini. Always have to be doing something,
Yeah,
multiple things at the same time.
right.
All right. This person says, I'm a outpatient oncology nurse, and we care for many patients with sickle cell. We recently been treating patients from the Middle East. I've tried to explain and educate. So, It's not really a question, but yes, sickle cell, one of the places you find sickle cell around the world is the Middle East. Can you speak to that, Dr. Q?
Yeah, people in North Africa, the Middle East, up in there, that they tend to have higher levels of fetal hemoglobin. So I don't know what. So anybody who comes into your practice from another country or didn't have newborn screening or it's kind of a little shaky, you should make sure that you know what kind of sickle cell disease they have. What is their fetal hemoglobin? Not just like you just want to know to be able to provide the best care is to find out, really what is there, because a lot of people don't really know. They know they have sickle cell disease, but they don't know what the genetic, what type of sickle cell. And when you start getting into North Africa, the Middle East, and into the Mediterranean and into India, there's a lot of sickle cell disease in India. You start seeing people who have S beta zero thalassemia, S beta plus thalassemia, or other kind of unusual combinations that present as sickle cell disease. So you need to know what the actual type of sickle cell is. When you get people from even within the United States, if you can't get that from their previous caregivers, then you need to do it. It's a simple test, but it gives you a lot of information.
Okay. How does Endari work?
That's a good question. Oh.
That is actually a really good question
A lot
because,
of
yeah,
doctors wonder how Endari works, but it does. It's an antioxidant. So, well, um, the reason why it even got uh, uh, developed was because a physician realized that people who have sickle cell disease are really low in L-glutamine. And he couldn't really, why is that? And so he studied it and he gave people L-glutamine, and it seemed to make their sickle cell disease better. Um, we just lost you on.
I'm still here.
Uh, anyway, see, it seemed to make people better. So he partnered with a pharmaceutical company, and they made L-glutamine. They did a study. It showed that L-glutamine actually decreased the symptoms of sickle cell disease, acute chest syndrome, and pain. So um, it's an antioxidant. It's an amino acid that's very low in people with sickle cell disease. But even now, I look at the literature a lot, and even now, people aren't really absolutely sure how it works because you're adding something that is a natural um, amino acid into somebody, and you just know that it's an antioxidant, that it does do things, but nobody knows exactly the mechanism behind L-glutamine, but it does work. It's one of the few, we lost voxel, crizanlizumab and
Voxelotor,
voxelotor.
Oxbryta.
And so L-glutamine is one of the medications, along with hydroxyurea, that is still considered to be a safe, well, L-glutamine safe drug to give to people without hardly any side effects. If you take hydroxyurea, you do have to get lab work and make sure everything's going okay with that, and your fetal hemoglobin is actually going up. But L-glutamine is, I personally, I think if I had sickle cell, I might take both L-glutamine and hydroxyurea. But you need to talk to your doctor, make sure there's not some reason why you shouldn't be taking one or the other. Everybody's different.
All right. Is it possible to get a stroke at a young age? Because I have been living with it when since I was 5 years old. So I guess
Yeah.
the question is it possible to get a stroke with sickle cell at a young age?
Yes, absolutely. So back in the day, the kind of average age for people before there was any therapy to have a stroke is about 9 years old, or even a little bit younger. And so what happened in the trying to remember exactly when it was the stop study in early 1990s, I guess 19. I can't remember. I'm getting old. But anyway, so the STOP study used transcranial Doppler, which is a looking at using ultrasound to look into to measure the velocity of the blood going through the arteries in people with sickle cell, children with sickle cell disease. You can't do it very well with adults because our skull gets thicker and thicker, and kids have really thin bone, so you can actually measure the velocity of the blood going through their circulation in their brain. And as that velocity gets higher and higher, your stroke risk gets higher and higher. And so they did a study looking at it was funded for 3 years, but in 18 months, they realized that you could prevent strokes by doing a transcranial Doppler, identifying people who are at high risk, starting those people on transfusions, and then they didn't have a stroke. After that was studied and it was became standard practice, they decided, well, do people have to be on transfusions forever? So what they did was, which I hate to ding people, but what they did was they stopped transfusions in some, you had to be in a study, sign a consent and all that. But they would stop the transfusions and they realized your stroke risk went back up after a long period of time on transfusions, that when you stopped them, your stroke risk came right back. So Russell Ware, who really likes hydroxyurea and has done a lot of research with hydroxyurea, worked with Bob Adams, who developed um, the transcranial Doppler. He's a neurologist, and they decided they would find people who had high levels, had high velocities, but they didn't have any really obvious intracranial problems or circulatory problems, and they would wean them off of their transfusions and onto hydroxyurea. And what they realized in a selected group of children and young adults who had stroke risk, if you did that and weaned them onto hydroxyurea, the hydroxyurea in those selected patients, not everybody, but in those selected patients, prevented stroke risk. So now people, after they've been on transfusions for about a year or so, they look at to see whether or not they couldn't be put on hydroxyurea instead of transfusions. So that's kind of the story. But yes, young children can have strokes. And as you go through your lifespan, stroke risk increases when you get to be an adult, an older adult. So there's a risk of stroke throughout the lifetime of a person who has sickle cell disease, particularly if they're not in any kind of therapy.
All right. This question is from individual that is about to turn 65.
Oh, good
Um,
job.
it sounds like this person, their doctor just retired, right? Um, and so they have to begin, and it sounds like they've been with this doctor for a very long time, and they have to begin anew, which is an underrated problem. I don't think we talk about that enough, like
No,
just kind of
it's like
transitioning
we
from doctor to
right.
doctor.
We talk a lot about transition from an adolescent, young adult into,
Yeah.
but we never talk about you're an adult and you lose your doctor. Then what do you do?
Yeah, what to do. So, um, just to get she's saying or this person's saying, I'm sorry, I don't know if it's um but they're saying I'm currently on my fifth appointment just to get my regular prescribed RX. So just to get their prescriptions. I recently saw a warrior stating four things to require as part of your medical. Is it required a hospital plan? Can you elaborate? I really hope my question is answered because I'm about to turn 65, starting all over again. I advocate for us geriatric patients, but most care is for 18 and under and not for adults. So, um, hopefully you are still online and we can answer this question on transitioning not from pediatric care to adult care, but your doctor retires, which is honestly sounds like a nightmare to me. Um, and you have to find a new doctor.
Right. So if you're still in touch with that doctor, I think one of the things to do would be to ask, which you must have done, or you wouldn't be asking this question, but try to find out from that person who they would recommend you to be seen by. The next thing would be to um, look through, try to find a hematologist or someone or a program near you, which could be difficult depending on where you live, who that has a sickle cell clinic and a center, and then with an adult program. Um, the next thing to do would be to go to the Sickle Cell Disease Association of America, and they have a list of doctors in states who take care of people with sickle cell disease. So the and this is, United States is a huge country. So you could be somewhere where there aren't any doctors who take care of people with sickle cell disease. And so it's recommended that you find a hematologist or a good uh, provider who is willing to learn something about sickle cell disease, and at the same time, at least once a year, maybe twice a year, you might have to travel somewhere to see a sickle cell doctor, like a hematologist or someone who is a specialist in sickle cell disease. So that and you could contact the Sickle Cell Disease Association of America, and they would know who took care of people with sickle cell disease in your area. And there's also an organization that Cassandra probably knows that is an organization of sickle cell centers in the United States. And so that's another avenue to find someone who takes care of people with sickle cell disease. Like as Cassandra said, it's I don't know if nightmare is the right word, but it would be very, very disconcerting to me if I had sickle cell disease and my doctor retired and I had to go to find a new doctor. I would be freaking out. Especially if
Yeah.
you're older and you're kind of used to, like,
Yeah.
and
Yeah.
you don't have a parent to go out and find you a new
I
doctor.
mean, that's true too.
Yeah.
Yeah, that's not easy. But it's so first of all, it sounds like you have a established doctor, so make sure that that person is the right fit for you. If you are still shopping around, there is a website. It's sicklecellcenters.org. And the organization, I sit on actually the board of the organization. It's a National Alliance of Sickle Cell Centers, helps people to find sickle cell centers near them. And so I think the goal is for you to continue getting care for sickle cell, which I know is really tough because there are so few sickle cell specialists. So I would say first is, finding a specialist, making sure they're a good fit. And then yeah, you build from there. It is it really sucks. I really just empathize with your situation because I get along so well with my doctor, and like, where I would even say we're friends. So to have to start rebuilding from scratch, and this is somebody who knows your whole health history. And I think that's one of the selling points on having a sickle cell provider is that this person has followed your health for so many years. So they understand your health history. So when your name comes up, they know, oh, this person has this, and um, they can help within the ER, they can advise on your behalf. And so if possible, I would also just have the two link up, your doctor from before, um, and kind of just have somewhat of a handoff. I don't know if people do doctors do that, Dr. Q, especially doctors that
They
are
should do that, but if somebody retires, they may
they,
just
they
disappear.
don't they don't want to I'm done.
I'm retired. But it's a big deal because when I was in private practice before I did a lot of things before I started taking care of people with sickle cell. But when I started working at Children's Hospital in Oakland, I really annoyed my wife because I used to stay up until midnight every night reading the charts of the patients because they're so complicated that it took me like 2 years to really read the charts and know something about all the patients I was taking care of. So people with sickle cell disease have a lot of problems, especially if you're older, or you could have a lot of problems. And so you need to have someone who's willing to sit down and learn about them. The other thing you can do is you have your medical record is your medical record. That belongs to you. And so you can ask the hospital and the practice for your medical record, a summary of your history with them at this doctor's office. And even if he's retired, if there's still an office, if there were more than one doctor, get a summary from them. And if you've ever been in the hospital, which I'm sure you have if you're older, get a summary, get your medical record from the hospital. And it's a weird thing. It's your medical record, but some hospitals will say, yeah, but the paper's ours. But the record, the information is yours, and you should be able to get that from hospital, doctor, wherever. And you need that, and if you do get it, then make a copy and keep it for
And then
yourself.
if they already have an individualized care plan, that should help with some of the transition too, correct?
Hmm?
An individualized care plan.
Oh, the individual. Yeah, so the person who's taking care of you needs to sit down with you and work out a care plan. What's important to you? What may be important to him may not be that important to you and vice versa. So you need to have a care plan. In particular, you need to have a care plan for pain episodes, or um, you need to have your history if you're older, so that when you go into the hospital somewhere where you're not known, you have your medical history and you have a care plan so that when you're in the emergency room, they know what, major complications you've had if you're older, and then how to treat your pain as prescribed by your sickle cell doctor. And on that plan, there should be a way to contact that doctor, or even if they can't contact your particular doctor, most people have in a practice, they share information. So somebody whoever's taking care of you that doesn't know you needs to be able to physically see your care plan, your pain plan, and also have a way to contact the doctor in case there's something unusual that they want to run by the doctor to make sure what they're doing is appropriate. Doesn't
Yeah.
all, a lot of doctors aren't real, they're not sharing people. So you might go to an ED and they just, you know, they look at your history and they go, oh, that's kind of interesting. And then they just put it, so they think they know. A lot of people with medicine think they know more than what they really know, which is
Yeah.
dangerous.
Yeah.
But if you have that written down, most doctors, 99% of doctors will say, oh, you take this, this, and this. And you say, yeah, that's usually what I get. And then that's what you get. Or they might say, oh, you've got chest pain, but you've had acute chest syndrome like 3 or 4 times. Maybe we need to work you up for acute chest syndrome.
I see a comment here that says it could suck if you don't live in a major city. I got sick once in Austin, Texas, and the ER didn't know how to handle it. They had to Google it, what to do, and then they asked me what my treatment is. So this is why an individual care plan is important, and this is why a pain plan is important. So those two documents to carry around this should take the guesswork out of what treatment should look like. But I think you bring up a good point. Like, I feel like this is just my 2 cents, guys, but I feel like if you have sickle cell, you cannot live in Montana. You cannot live in like, just out. You need to live near a city, in a city or near a city, right? Where, that's where research is typically done. That's where, you have the most resources for hospital. And so, my husband talks about like, oh, living out in the country where it's quiet and everything. And that's not necessarily attractive to me. I'm not like a nature girl or anything. Um, but honestly, I just feel like, we fare better when we are in more centralized places and, access is important. So, even I was born in Iowa and, Iowa sounds really desolate and, they're like, wow, no black people in Iowa and this and that. But I actually was near a sickle cell center in Iowa, in Des Moines, Iowa. So, um, I feel like that should lead people. Like, don't venture out to places where you won't be able to get care because then things can turn really, really bad. But then if you do, right, if you are adventurous, just make sure you have an individualized care plan and you have a pain plan, so that people kind of, this is a guide for people to treat you. And they may not follow it. I'll just be very real. Like you may hand them this paper and they're like, yeah, this is against our hospital policy or whatever, but they may follow it too. So it just betters your chances. Um, you should also have like an electronic medical health record. So, I have my health or,
My chart.
whatever my chart, all of that stuff so that that documentation can be within your my chart. And it honestly, I think it carries even more weight because, you can't put that stuff in my chart. It has to come from your doctor. And so you can just kind of show them from your cell phone, like, hey, this is in my chart, or hey, this is in my health, and they can follow it there. But I just wanted to call out that comment because it is very real. I've been in a situation. I went to go to Indonesia, to a secluded island in Indonesia, and got sick and didn't get great care and almost died. So I know that I learned from experience. So I just want to call that out, that comment.
Yeah, so if you get that, you can get a PDF of the care plan and put it in your phone, and then you can share that with people. You don't, in the electronic age, you don't necessarily have to have a piece of paper with everything on it. But Cassandra's right. If you have access to my chart and your doctor has put your care plan into my chart, that carries a little bit more weight than here's my care plan on a piece of paper, because they might think, oh yeah, this person, they're a drug seeker and they wrote this and signed it, or something, whatever. But if it's in my chart and your doctor's written your care plan into that and you can show it to somebody, that probably helps a little bit. Also, it is a bummer that you can't live outside. I talk to people who had to drive like 45 minutes or 2 hours to go see their sickle
Yeah.
cell doctor. So, that's, if you need to live somewhere because that's where your job is and all that, but it is dicey to live out into the middle in Iowa somewhere.
And somebody also said if you have a significant other or someone you trust, look into making them your proxy. Absolutely.
Yes.
There's power in numbers, even when it comes to getting care. It helps it helps lessen the load for, um, just anything that you're going through in the ER or in clinic, having somebody who knows just as much about your health as you do is helpful because, when you're in that pain or wherever, it's really hard to articulate what you need. And so having that person is important.
And I've never thought about that, but most people, you have a parent, you have your spouse or somebody, a significant other, but you could have a person who is sort of your advocate, and you can empower them to come to the ED with you. Because usually, even if you're with your spouse, they'll say, no, 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 only the patient can come back here. And somehow you have to get around that too, because it really helps to have another person in the room with you when you're talking to the doctor. It changes the dynamics a lot.
This comment says, I'm not black. I have a percentage. Or, okay, I'm not black. I am a percentage and have SC. Yes, so sickle cell is not just a black disease. It's common, Dr. Q mentioned it's common in India, in the Middle East as well. You find sickle cell in the Caribbean islands, in Latin America. So it's Mediterranean. So it's not just a black disease. Thank
And
you for
and
sharing that. A lot of people do think it's a black disease.
and I had a lot of, because we're in California, I had a lot of Hispanic patients who had sickle cell disease.
Yeah.
And since we're talking about the ED, that really shocks people when somebody who's not black comes in and they have sickle cell disease. Then you really
Yeah.
are a drug seeker. You wouldn't be here, you know. And I had in a friend of mine who worked in Tennessee said that he had several like look like me patients who had sickle cell
Mhm.
disease, and I only had one or two kids who had like blue eyes and blonde hair and had S beta 0 thalassemia. And as they grew up, I could just imagine they're going to get a lot of pushback when they walk into an ED with a pain episode.
I see a follow-up question. What was the two plan named again? It's an individual care plan and then the pain plan. Is there any
Right.
other ways that those might go?
I think yeah. I mean, that's it. An individual care plan, a real, you know, I guess if you wanted to be thorough, you'd have like your history, you know, you've had these different problems, and then but the pain plan is the one that's going to help you immediately in the ED.
Yeah, both serve as different things. Um, Somebody says Free Time TV says this was my doctor from the age of 10 to 12 at Oakland Children's. He's my doctor too.
Who is that? I don't see it.
Free Time TV. If you're still on, feel free to say hi.
Hi.
Um,
I miss
So I'm
everybody. They're all grown up now, though. They're all
yeah,
adults.
he still calls us his kids. And I'm so grown now, guys. Like
Yeah, before we started, I was calling her a kid. She didn't like it. But when you get to be
at
my
my big age.
when you get to be my age, 90% of people are kids to you.
All right. I am somebody they just turned 25, that person. Somebody asked, please answer my question, but I didn't see your question. So if you don't mind putting the question in again, Gadget City, Kenya. I didn't see your question, so let me see if I can find it. But if not, could you please put it back in the chat? The next question that I have here is, um, how does gabapentin help with sickle cell disease pain crisis? I've never heard of gabapentin.
Yeah, it's a neurologic drug. Everything that happens, to be okay, I'll be honest, I don't know exactly the pharmacology behind that. But people do give it a lot, and it's a central nervous system acting medication that helps people with sickle cell disease. And I don't, off the top of my head, know the pharmacology of why that would be helpful. But it's used a lot, and I would use it in people who had chronic pain.
Okay. Um, what can cause a silent infarct? Sickle cell.
Uh,
Oh,
Silent infarcts are really, really common in sickle cell. And silent is kind of a misnomer. So any infarct that you have does something in your brain somewhere. So the reason why they're called silent is because you appear to everybody around you, including your doctor, as being completely normal. You do not have any obvious neurological problems. You just look normal. But if you have a lot of these very, very small infarcts, really small, that you'd have to use an MRI or they might not even show up on a CT scan. You'd have to use MRI. If you have those in in a significant numbers, it can really affect your intellectual functioning. Not it maybe not a lot, but enough so that you'd really, if you were a kid, you'd really have trouble in school, or if you're an adult, you might have trouble at work. And they occur persistently throughout your life. Like even in older people, like I probably have, if I got an MRI brain scan, I would probably have some small infarcts here and there. The problem with it is in children, in adults, well, let's start with in adults, the problem is you could be having trouble in your workplace because you understanding things and trying to follow directions and stuff. And it could be because you have silent infarcts, because otherwise you look totally normal. In children, the same thing. And the only way to pick it up in children is to do neuropsychological testing, where they try to figure out where are the deficits in this child. What do they need help with? Do they need help with math, reading, behavior, or something else? And so neuropsychological testing can pick up the effects of having silent infarcts. And they're not silent. They just do not, when you look at somebody, you just don't think there's anything wrong with them. But if you
yeah.
did a neuropsych test, you'd realize, oh, they have these little deficits for reading and understanding and stuff like that. Very common, very common. And they are a risk factor for overt strokes or a bigger stroke. Michael DeBon, who's hematologist, has done a lot of work with silent infarcts, whereas Dr. Adams did infarcts type of work.
All right. I found your question, Gadget City, and I see that you reposted it. So thank you for doing that. So this question is, I've been looking at that new sickle cell treatment they're bringing to Africa. It's already used in the US to help stop pain crisis before they start. It sounds like a massive breakthrough, but I'm curious, have you heard much about it? I'm trying to see if it's actually a safe move for um, somebody with sickle cell to try out. So, what it sounds like you're describing is crizolizumab, which is a P-selectin, and it works to make things less sticky, right? Which sometimes that stickiness is a contributor to crisis. Um, Crizolizumab is interesting. The brand name here in the US is called Adakveo. Dr. Q, can you share a little bit about
Yeah,
Criz or
yeah,
Adakveo?
crizolizumab is a P-selectin inhibitor. It's like an antibody that blocks this sticky um, uh, molecule on the outside of your red cells, your white cells. It lines on the lining of all your blood vessels. And by blocking that, the idea is that it it will decrease the stickiness. That's kind of a weird way to say it, but it's the adhesion uh,
Adhesion.
of this between these molecules, and the blood will flow smoother, and you don't have uh, sickle cell events because the red cells, platelets, and white cells can't get together to do whatever. So there was something called the STAND study, which was done in Africa across across a lot of different areas. And unfortunately, the STAND study in Africa, this is my own opinion. I don't know, I didn't have anything to do with the study. I've just read about it. But to me, it seems like they had a lot of people on crizolizumab spread out over several countries, and the healthcare in those countries were not identical, and they were out of the control of the pharmaceutical company that was testing this medication. So it turned out that crizolizumab was no better than placebo in the study in Africa, which really caused the European medical uh, control people to say that they no longer recommended or would allow crizolizumab to be used in the EU. In the United States, it's still available, um, but it really it changed people's view of crizolizumab as a medication that would be helpful for people with sickle cell disease. It probably is helpful for some people, but in a population study, it was not helpful. It was no better. The doses that they used compared to placebo did not make any difference. And in the original studies of crizolizumab, the lower doses were not effective. Only the higher doses, which makes sense, only the higher doses were affected. Um, but it really put it just made things more difficult for people with sickle cell to find a medication. So that and voxelotor, both within a pretty short period of time, they were both found not to be that effective or not effective at all. In the case of voxelotor, they felt that it was more, the risk of it was higher than the benefit, the pharmaceutical company, when they looked at all the studies. So yeah, those two drugs really took a big hit. And they aren't as they don't seem to be, well, particularly voxelotor, they don't seem to be as helpful as people thought they were. And crizolizumab, there have been other studies to show that in like with priapism, maybe, and some other things that may be helpful. So it's when you're talking about this kind of therapy, you really need to talk to your sickle cell provider who can go through this with you and explain exactly why you should or maybe shouldn't take it, or whether it would be
Yeah.
helpful for you for your problems. So, although
Yeah.
it's not, voxelotor is just not available, period. So that's a different story.
Worldwide. Yeah. So, in Europe, the drug crizolizumab is not being used. It is being used here. It's interesting because with a lot of these clinical trials or a lot of these studies, the data shows that there are people who are responders and non-responders within these studies. So just going to, not everybody with sickle cell will react. Not everybody reacts to the same drug, period. Like, your reaction to Tylenol could be completely different from somebody else's reaction to Tylenol. So it's the same concept with a lot of these medications, right? Where um they kind of bunch all of sickle cell together and all people with sickle cell together, right? And sometimes when it doesn't work for somebody, there's a company or there are people who are trying to understand who would this particular drug work for? Like, what is the profile of that person that this particular drug would work for? Because this drug may not work in everybody with sickle cell. And so I think it's also important to think about, some people could be responders and some people may not be responders. And that's there's work being done to understand a little bit better, like, how is this person's sickle cell with SS different from this person's sickle cell with SS, different from this person's sickle cell with SC, and so on and so forth. And so that was I think that's another important point to consider is like, with a lot of these clinical trials, not everything's going to work for everybody. But they do provide it here in the US still, but they do not provide it in Europe. And I don't know what agency oversees Africa or what they're going to be, who they're referring to, whether it's the WHO. A lot of times, a lot of African countries refer to EMA or, those in the UK. So it'll be interesting to understand how African countries are looking to potentially bring this drug to Africa, but oftentimes they work closely with, their own medical agencies within the country, but then also external agencies as well.
The other thing about in this drug in Kenya is that, frequently before a study is published, you don't people, especially here, would not know what the drug would be in Africa because it would be given by the pharmaceutical company and they would be doing a study. I would have to look it up under clinicaltrials.gov on the internet because they have all the trials that are in process that are registered with the United States. And if this drug was manufactured in the United States, then they would have to have their trial on clinicaltrials.gov, and you could look through that and figure out where it was and what the drug was. But I don't.
Do you remember, Dr. Q, what the safety profile is? So this person has a follow-up question. So is it dangerous? And what can you advise
For what?
for a doc feel for the crizolizumab?
Uh, it's not like voxelotor. I don't think it's dangerous. I think it's more that it is not effective. Um, uh, the drug company said their safety profile, even though it wasn't better than placebo, the safety profile showed that it was safe. So I think in that term, it's safe. It just in that context in Africa, it just did not perform better than the placebo at any dose, which that really changed people's perception of it. So. And that
Yeah,
and that was their trial. That was kind of the trial that was going to show people that this drug can be used anywhere for any people, no matter what the resources were. And it just didn't show that. So,
yeah. So what, just a quick Google search, and please don't, you'll have to do your own research on this, but it says here it's generally safe, that therapy. And so like Dr. Q says, it's more so of an efficacy issue than a safety issue.
right.
And then it says some of the common adverse reactions or nausea, back pain, and some things I can't pronounce, arthralgia,
Arthralgia. Yeah.
arthralgia,
Yeah. So,
and pyrexia.
yeah, fever.
Yeah. Yeah.
So
Okay.
it meant when you got the infusion, you would have there were side effects to the infusion that went away after some period of time. But some people felt like the fact that you had pain and problems during the infusion had something to do with its efficacy. I don't know about that though.
And then what, another follow-up question, what is the monitoring like when using the drug?
Oh, for crizolizumab,
Yeah.
I don't think there's any special monitoring for the drug, except you know, keeping track of your symptoms and making sure that it's actually working for you. I'm not aware that there were people who during this trial who stopped taking the drug, and some people who had just stopped because they didn't want to take it. And then there were people who had side effects from the infusion who stopped the drug because they just didn't like the side effects of the infusion. So I'm not aware that anybody ever had to go into the hospital after the infusion or have treatment after the infusion because they got so sick from the infusion. Although that could have happened, I can't recall that I read that. The upshot of it from the pharmaceutical company was that it proved that it was safe but not effective in that population.
I see a question here about hydroxyurea. It says, do you know why the cost of hydroxyurea is high? Paid $886 in the Bay Area. I don't pay that, and I'm in the Bay Area.
Yeah, I think you have to look, you have to sort of shop around because I think that there are, the med medicine is not the same everywhere. There are I forget what they call them. There are like middlemen in the pharmaceutical companies. So the pharmacy gives the right to sell the drug to another group of people who then sell it to the pharmacies. And depending on how that is and where they are, probably depends on what you pay for the medication. But I don't know the details behind that. But I know that the there is a chain of people who have that drug before you see it in the pharmacy, and that can affect the price.
How are you doing on time, Dr. Q?
Uh, Mom, Grammy just went to get my granddaughter, so I'm fine.
Oh, okay, okay, all
I
right.
got the little note. Should I go get your our
Oh,
girl?
okay.
And I said, sure, go get her.
Nice, nice. Okay. So we do have a couple more minutes for maybe one or two more questions. I really want to answer something that somebody is like dying to know. I do have, there's so many questions here. If you're like dying to get an answer on this live, like right now, put your question, even if you put it in already, put your question in there. And whoever I see first will answer those questions. We'll probably do two more questions. This is a good quick question we can answer while I'm waiting for your guys' question. Why are we doing hemoglobin electrophoresis before starting hydroxyurea? It's to establish baselines. Dr. Q, do you have anything to add to that?
Yeah, I mean, the idea is that what hydroxyurea is supposed to increase your fetal hemoglobin. So there are people who have high levels of fetal hemoglobin to begin with. Um, and so they want to see whether or not the drug is actually effective for you because the idea is you start at a low dose and you work your way up to the maximum tolerated dose. So part of that um, procedure is to see that your fetal hemoglobin is increasing as they increase the dose. So they need a baseline just to be sure that the fetal hemoglobin is going up. Because that's why you're taking the medication. It'd be like you take aspirin, so then you take your temperature to make sure your temperature went down after the aspirin. The same thing. They want to make sure that they're giving you this drug that has side effects, but that it's actually working for you and increasing your fetal hemoglobin.
All right. Gadget City, I'm gonna put the website in the chat right here where you can learn more about Adakveo or crizolizumab. Um, and then I think I got my questions here, so thank you. Um, mm, 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 mm. Is the lungs fixable? Oh,
The
oh, oh,
lung.
oh, oh. Before you answer that though,
Yeah.
sorry, I see another question. Saw another question coming. Okay, we'll do the is the lung fixable, but first, I work from home and sit most of the day for work and school, and I often feel low energy even though I take my medications. What else can help? I'm assuming you have sickle cell.
Yeah.
Um, your life sounds a lot like mine. So what do you think, what can we do? You're in front of the desk
Well,
all
I
day long and your
there
energy is
was a
drained.
study that just came out that they were having people walk and they were counting, as I recall, they were counting the steps that they walked. And
Mm,
so those people just getting, this minimum amount of exercise increased, decreased their pain and increased their well-being and their ability to walk. And so, they would walk, I can't remember, say 100 steps,
it's
200 steps,
10,000 steps.
10,000. Yeah, that's
Yeah.
that's what they tell you. That's like almost 4 miles, actually,
Yeah,
depending
that's
on.
my goal. That's my daily goal, 10,000.
Yeah.
Yeah.
So if you have your Apple Watch, you'll know how many steps you took. But so in the study, it just showed that people who did more walking were in better shape, had less fatigue. A part of fatigue is just, your whole body kind of like when you're just sitting doing nothing, everything slows down. So you would feel fatigued. I know I feel better. I go
Yeah.
for, you know, long walks if I'm not exercising just to get things moving a little bit. So but fatigue is really common in sickle cell disease and it's really understudied. So people don't know, besides anemia, people don't understand why people with sickle cell disease have the level of fatigue that they have, because sometimes you feel better after a transfusion, of course, but then within a week or so, you're kind of back to, is that right? You know,
Yeah,
you're
could
kind
be.
of
It
back to
depends.
your baseline, which you really
Yeah.
shouldn't be because your hemoglobin's still up pretty high. So I don't,
It's
it's,
fatigue from the new blood. Like, your body's processing all
yeah,
this new blood and it's
yeah,
it's, it's fatigue. No, I'm
yeah,
playing. But yeah, just the goal is to keep moving, in between meetings. I bought one of those walking pads. They're about $100. But you could I've been really into, like, if you look at my timeline or my feed on Instagram, you'll see like a lot of stuff just like for desk setup. So like chair ergonomics, right? And a walking pad and like a one of those desks you can raise up and down. And that stuff can get really, really expensive. So you got to get creative with that because I ain't got like $5,000 for all that. But I at least had $100, and I get some of my steps in through a walking pad, and it's pretty slim. It can go under things easily. I've even seen folding ones as um folding walking pads as well. So I think the goal is just to kind of keep moving to keep your energy up. And then I have some coffee sometimes too.
But in terms of just decreasing, you can get deep DVTs from just sitting too much. So uh,
Yeah,
yeah,
I
and
heard
I
sitting
don't
all
know
day
if you
is
need
really
a
bad.
walking pad, but you do need to get up and walk around the room or stretch or do something. You can go online and they will tell you what people do if they have an office job. There are a lot of things you can do, and you can invest in things to help you um, be more you use your limbs a little bit better when you have to sit down a lot.
Okay, I'm gonna rapid fire these next questions.
Okay.
Are the lungs fixable once they're
They
damaged?
are fixable, but the disease process is progressive. So you can take medications to increase your ability to breathe and all that, but over a long period of time, if you have asthma, you've had acute chest syndrome, those things do take a toll. So when you get to be in your late 30s, 40s, then you may have chronic lung problems. Um, it's called restrictive lung disease. So yeah, it's fixable immediately, but over the long period, especially if you have chronic lung problems like asthma or acute or reoccurring acute chest, those things tend to damage your lungs that isn't repairable.
Yeah. Um, a lot of people don't know sickle cell is a progressive
Yeah.
disease. So it's not, even though you're not in crisis or you're not having a pain crisis, that damage is still happening. Sickling is still happening. Oxygen is still not being delivered very well all throughout your day, even as I'm talking to you right now. So that's the thing. People don't know that it is a progressive disease, and so it kind of wears away at your organs. And so it's important to slow that damage down. And one way you can do is through blood transfusions. You can do it through disease modifying therapies like hydroxyurea. So that's the goal, is really to slow down that damage that sickle cell wreaks on the body. Um, Hydroxyurea in pregnancy, would not recommend. And that's just because, a, a lot of drugs you can't take during pregnancy, right? Because you want to keep your baby safe. So, Dr. Q, do you want to share a little bit more about
Yeah,
hydroxyurea in pregnancy?
there was a study that showed that women who took hydroxyurea and sometimes through their whole entire pregnancy because they were so sick, the babies seem to be okay, but we're not talking about a lot of babies, and a lot of women who took hydroxyurea through their pregnancy. But it's not recommended that it is what's called a teratogen. So it can, at higher doses, cause birth defects in the fetus. So, but there are plenty of it. There's a lot of information about people who continued to take hydroxyurea because they didn't realize they were pregnant. And then when they did, they stopped the hydroxyurea and there was no problems at all with their children. A recent study, some of the women continued the hydroxyurea into their pregnancy, and I can't remember, but not a lot, but some of the women continued the hydroxyurea throughout their entire pregnancy because they were so sick. And the babies were all fine. So it's a small group of people. There hasn't been a big study, but it appears that perhaps at the doses that people who and I can't remember the doses these people were on, but at the doses that are given to people with sickle cell disease, it does not appear to be a teratogen. It the reason why we know this is because they gave very, very high doses to rabbits, and their and the litters when they had babies were had problems. So that's how they know that it's a teratogen. They gave doses you'd never give to a person to see whether or not it would cause birth defects, and it did. So technically speaking, it is a teratogen, but perhaps not in the doses that people with sickle cell takes.
Um, Ingbird, I just posted the website and where you can find sickle cell center near you. So hopefully that helps, and hopefully there's a center near you. I'll also just keep in mind a lot of times, a lot of the doctors do telehealth. So maybe if they're even within your state and they're accepting new patients, maybe they don't have to be right next to you, but they could be hours away, but can still see you through telehealth. You just kind of have to ask if that service is available. Um, and then the last, we'll wrap up with this follow-up question from the person who was asking about lung damage. They're in the process for a bone marrow transplant, age 14. His brother is his donor, but we found out yesterday that he has some lung damage.
Right. So that would not, I mean, he's 14, so the lung damage could be there, but in reality, if you look at the studies, uh, there are improvements in pulmonary function, kidney function, etc., after a bone marrow transplant. So it's not, I don't think anything's ever guaranteed in medicine, but his lung function could improve, especially since he's 14, after he gets his bone marrow transplant and doesn't have all the complications of sickle cell disease anymore. So by the time he's 20, he may have normal lung function, or maybe, in a few years. So if he's getting a bone marrow transplant, they're going to, depending on how, what you mean by his lungs aren't normal, they will take that into consideration during the transplant, make sure it's not a problem.
I see you guys sneaking in questions here as we're wrapping up. Y'all think you're slick. Yeah, I'm playing. Um, okay, Dano. Last question. Some sickle cell patients with low hemoglobin level, after given blood transfusions, their hemoglobin rise higher. Example from 3 grams per deciliter to 10 grams per deciliter. What can be the cause? So that's the point of the transfusion, is to raise the hemoglobin. Your people with sickle cell have low hemoglobin, and so the goal when you're getting transfusion is to raise the hemoglobin. Dr. Q, what can you add to that?
So there's two ways to get a transfusion. One is called a simple transfusion, and you walk into the day hospital or the transfusion unit, your hemoglobin's 6.5, and they figure out, oh, we want this person to have a hemoglobin of 10. And so you can figure out using weight and etc. And your hemoglobin that when you leave the transfusion unit, maybe your hemoglobin is 9.5 or 10.2 or something like that. So that is a simple transfusion. and you feel better because you've diluted your sickle hemoglobin with normal hemoglobin, so the oxygen carrying uh, function is a little bit better with the normal hemoglobin. So the problem with that is that when you do that, you get a lot of extra iron. Iron is in the red blood cells and it helps the red blood cell carry oxygen. There's no way to get rid of iron from your body. Your body, over, evolutionarily or whatever you want to call it, your body wants to hold on to the iron because the iron helps you not be anemic. But in evolution, people didn't get transfusions. So there's no way to get rid of that iron from that transfusion. So you have to check your ferritin and you have to take a medication orally now in order to get rid of that iron, to help you get rid of the iron. Eventually, iron will cause heart disease, diabetes, some some degree kidney disease, etc. And people who get simple transfusions like that over time, usually if they don't chelate, it's called chelation, they will die from heart disease because the iron will poison your
Yeah.
heart. So you really need to be on chelation if you're on chronic red cell transfusions. And even if you get a few a year, you need to know what your ferritin is to make sure over your lifespan you're not your iron level isn't too high. Um, it also affects what if you're going to go into like this person is going to get a bone marrow transplant. If you have higher iron levels when you get a transplant, that affects your recovery from the transplant. The other way to get transfusions is called exchange transfusions, where you figure out how much blood you need to get your hemoglobin to 10, and when at the same time you're taking blood out. So you're taking the sickle, initially it's mostly sickle cell blood out, but as you give the transfusion, of course, you're diluting out that sickle cell blood. So at the end of the exchange transfusion, not as much sickle cell blood is being drawn out as you're giving more. Um, the difference between the two is number one, when you get an exchange transfusion, you're probably exposed to twice as many units of blood at least than a simple transfusion. Um, and you're not going to get, well, you might, depending on how they do the transfusion, but you're less likely to have iron overload. And if you do, it takes much, much longer to get iron overload with an exchange transfusion. Um, so that's really the difference. And the other thing is with an exchange transfusion, since you're removing the sickle blood, you can figure out what the end hemoglobin is going to be, and you really decrease the sickle. You're not just diluting it out, you're actually removing the sickle cell blood. So the amount of sickle cell blood you have at the end of an exchange is really low. It can also be done relatively rapidly because it's done on a machine. So it can be done in a shorter time period than a simple transfusion. Um, when you get a simple transfusion, the other thing is you can't transfuse too high because depending on where you started with how anemic you were, because at some level, the viscosity or the kind of sludginess of the blood can cause problems like hypertension and stroke. So you don't want to have a really high hemoglobin after a simple transfusion because that could not be good for you. But if you're in
Yeah.
simple transfusion, even maybe or less likely, but maybe with an exchange, you need to know what your ferritin is, be the simple test, and you need to be on a chelation if your doctor tells you your ferritin's too high. Do not get, don't, don't not do your chelation. Uh, I can't emphasize that much. You're doing something to make your life better, so don't kind of
Make your life worse.
make your life worse
Yeah.
by not taking your chelator. And you just have to do it. There's just,
No way around that.
there's actually a debate among, well, there was when I was practicing, should we transfuse people who don't do their chelator? Even though you have stroke risk, we know you're going to die from iron overload. Should we just keep giving you blood? Or should we say, we can't give you blood anymore. Your ferritin's 3,500.
Yeah, I
And
wouldn't.
if we keep giving you this blood and you don't chelate, you're going to die from iron overload, whether
Yeah.
so there's a debate about that. I personally, I had my own, I won't tell you, but I had my own feeling about that. I can tell you
Yeah.
it never stopped anybody's transfusion.
Yeah. So the goal is of transfusion is to increase your hemoglobin, just to bring that back around. For example, my baseline hemoglobin is 8. Usually I'll get 2 units of blood. So it usually one bag of blood is 1 unit for me typically. And so my before transfusion, my hemoglobin would be at 8. After transfusion, it'll be at around 10. And then I'm like Sonic after that. Like I'm bouncing off the walls, ready to do stuff, and then, just riding out that blood. But yeah, that is the goal, is to raise the hemoglobin so that, to dilute all the sickle cells and to hopefully increase your quality of life and
Yeah.
it decrease your burden for the disease. So,
And
Dr. Q,
and and
go for
usually
it.
people are on chronic transfusions for a reason. You have stroke risk, you've had a lot of acute chest syndrome, you have some other complication that that can be ameliorated by the chronic transfusion if you're on transfusion, or you've had a stroke already. Or in some cases, some people might advocate if you've had a lot of silent infarcts and you're affected by that, maybe you should be on transfusions as well. So I will tell you that we're gonna, no more questions, right? I can tell.
Yeah, I was gonna ask you to give your statement.
Yeah. So if you have any questions, you can always send it to ask at Sickle Cell 101 and I'll answer your questions. But just remember, in this part of the Sickle Cell 101 education, I'm just using my brain, which probably has a few small infarcts at my age. So I'm not, I don't have a book open in front of me, so I'm just using the information that I remember from doing this for quite a few years. And I'm not advocating that you take any kind of medication or treatment like transfusions, bone marrow transplant, hydroxyurea, crizanlizumab, something else. I'm not advocating any of those things, although we do talk about them. And this is just for education and because that's what Sickle Cell 101 is about. And in fact, you may want to question some of the information I've given to you with your provider. Dr. Q on Sickle Cell 101 said this, is that true? And he may tell you, nah, I don't think that's true, which is okay, because maybe um, I said something that wasn't 100% what it should have been, because I'm just talking from my experience. I'm not looking at a book to tell you what's up. So
He has
that's
a lot
it.
of experience, though,
Yeah, I do.
in sickle
And
cell.
this program is really good for me because it makes keeps my brain working. And frequently I'll start looking, somebody will ask a question, I'll say, I need to know more about that. Okie doke.
So we're all here to help each other. Thank
Yes.
you all so much for being here today. We
Yes.
hope you have a wonderful weekend. Happy Friday. Hopefully you are resting. Hopefully you are drinking your water. And what else do I want to ask you? Do maybe something fun for yourself or do something nice for yourself this weekend. You
And
have
if
my
you live on the East
permission.
Coast, wear warm clothes.
Yeah, stay warm. Stay warm out there. Thank you all so much for being here today, and we will be back next time, 2 weeks.
Bye bye,
See you
everybody.
later.
Thank you for
Bye.
tuning in.
Right.
That was fun.